Good morning, everyone, and welcome to the third webinar in our series of early psychosis intervention. Today's subject is best practices for administrators and clinicians. My name is Jenny Allen. I'm with the WICHE Mental Health Program, and we are working with ISA at the Portland State University and Wyoming Department of Health to bring you a series of webinars. I would like to hand over now to Ari Garcia. She planner with the Wyoming Department of Health. Ari, over to you.
Good morning, everybody. We're excited here to be having Ryan and Tamara from ISA presenting on the evidence-based practices for the 5%, or actually now it's a 10% set aside for the mental health block grant. We just received a notification that we got an increase to the grant, so we can now set aside 10% of the funding for first episode psychosis treatment. And so we're just really excited to be able to hear Ryan and Tamara present about the evidence-based practices today, and I will turn it over to Tamara.
Hi, everybody. Good to talk to you again this morning. And as already mentioned, there's been some really good news during the last week. One piece of news was that everyone has now received notice about receiving additional funding for these programs. And then the other good news is that we were confirmed for continuing education credits for this webinar and the next one after. So I apologize that we haven't had them previously, but we do have them now. At your request, and all you need to do is just be sure to fill out your evaluation and make sure that your contact information is there. Ryan, you want to say hi to everybody?
Yes, this is Ryan Melton. Nice to speak to those who've been on previous webinars again and meet those who are new. I'm the Clinical Training Director for the ISA Center for Excellence. ISA is the Early Assessment Support Alliance, the Early Psychosis Program in Oregon. So I'm the Clinical Training Director for our Center of Excellence, which oversees all the clinical practices and fidelity to the model in Oregon.
So this is the third in 4 webinars, and so today we're going to be talking about practices that we know to be effective in working with folks who are in the early stages of psychosis. And then we'll also be introducing you to some resources which are just out there on the web or easily available to you if you want to start moving forward. And then in the next webinar, next week, we'll really talk specifically and try to make that one pretty interactive with you around how do we actually start to apply some of these practices in your community? What can you do with or without additional resources? And so we've tried to tailor our conversation today to the communities that you have. I know you've got some larger towns, but you also have a lot of rural communities and very small mental health centers. So most of the practices that we're talking about are much broader evidence-based practices that apply to a range of populations. And so the more that you can integrate these into your routine practice as an organization, the easier it'll be to adapt it to the early psychosis population. I'm very, very fond of Pat Deegan. There's some wonderful people out there who have lived with schizophrenia or other kinds of mental illnesses and have written extensively about what they've learned about what works. And the quote, she wrote a piece called The Conspiracy of Hope. And the quote from her is, how do we create hope-filled, humanized environments and relationships in which people can grow? I mean, that doesn't sound a lot like evidence-based practice inherently, but, it's interesting as you look at the different practices, all of them have this word hope in the middle of them, kind of right at the forefront, and also the word relationship. So, it's as much as a relationship is not necessarily a practice and hope is not necessarily a practice. If we don't have those things in our relationships with these young folks, we will not be successful. And that, by the way, is my cat named Cuddles, who is a source of hope for me on a day-to-day basis. Okay, so we talked in our first webinar about the things that happen if you don't have early psychosis intervention available. And you all were talking about how people are kind of bouncing in and out of the hospital, ending up in trouble with the law, basically disconnecting from services. And we know that if we don't address the barriers to care, that is what happens. And you know, we talked a lot about the impact of that, but just to remember, you know, there are things that we're trying to accomplish through this. And so, you know, as we talk about the evidence-based practices, it's really essential to remember why we're doing it. What is it we're trying to accomplish? Because that gives us a little bit more leeway in terms of what we actually do with each individual person. You know, so basically we're trying to prevent these things from happening. We're trying to prevent people from being traumatized, having to go back to the hospital, being in relationships that are coercive and adversarial. We're trying to prevent family burden, and I would say divorce as well. We're trying to prevent people from being disabled for life, and if they do have to receive disability benefits, we want them to be able to participate at their full capacity. And of course, identity is a really critical factor for these young adults. So, you know, when somebody develops psychosis, it's easy for them to become very, very demoralized and to build their identity around the trauma that they're experiencing and the psychosis itself. And of course, you know, everybody talks about cost savings, but the fact of the matter is that we are spending a tremendous amount of money on this particular group of people. So this is a small group of people who cost a lot more than most folks. And in addition, the way that we're spending that money right now is actually not effective in preventing all the things on this list. So, you know, again, when we think about why are we doing what we're doing, you know, we want to identify people as early as possible before they've started to have all these serious consequences. We want to engage with them in a way that really emphasizes their strengths, their goals, and language that they find acceptable so that they're not running away from us. We also want to engage very quickly, very early with family members and to provide them with support and education, as well as partnering with them around the goals and what we're trying to accomplish. We want to make sure that when we're providing an assessment that it's accurate, because there's a lot of misdiagnosis that happens with psychosis. And so, you know, a big part of what these programs do is to offer accurate assessment. And then empowering messages. So, you know, again, this goes back to the identity. You know, people are very easily demoralized, that they can easily fall into a sense of hopelessness, especially if they go on the internet and start reading a lot of stuff on there. And so, you know, we're trying to kind of counteract that with realistic and empowering messages. And then careful prescribing practices, because one of the common things that happens is that people will drop out or quit medicine because they're having side effects, or because there's a grief process involved in accepting medicine, or because they feel better and they think maybe it was just a one-time thing. So, you know, really having a good prescriber on board who is going to have a positive relationship using shared decision making, and really, really pay close attention to side effects. Counseling, you know, is not just there just for the sake of it. We're trying to help people develop the understanding of how their particular symptoms manifest themselves, so that they can actually develop some level of mastery of that. We want them to continue to make developmental progress. So, if they're a high school junior, we'd like them to finish high school. We'd like them to think about their career. We'd like them to think about all the things that they would be thinking about. And then finding meaning, that's kind of an abstract kind of concept, but I spend a lot of time sitting with our Young Adult Leadership Council, and I hear them talking about their experiences of psychosis and the things that they've learned from it, the things they've taken away from it, how they frame it, how they talk about it. And some of these folks had their first psychosis, 8 or 9 years ago, and they're still grappling with what does this mean to me, so that they're not digesting all the negative messages about, this means you're disabled, this means you can't do things, but they're finding a context and a place for those experiences. And then, of course, not at the least at all, staying engaged in school and work. So again, that's the developmental progression, and providing support for that. We also talk a lot about peer support. So introducing people to the huge recovery community that's out there. There's so many people who are in recovery from this condition, who are willing to talk about it, who are really hopeful examples. And so letting people know that they're not alone, that there are a lot of people who have figured out how to navigate this. And the things that they've learned are actually quite consistent. If you start reading the recovery literature about what people have done, there are common threads throughout. So introducing people to those common threads that you can actually develop a sense of mastery of this. You can work your way through it. And then finally, building long-term supports, building community around the person. We know that social support is as impactful on long-term outcomes as medicine. So as we think about the evidence-based practices, we're really trying to change the way that things happen at the systems level, at the agency leadership level, practice in the community, and at the individual and family level. So, we're trying to kind of build a whole infrastructure around people so that they can have long-term success. So we always start with systemic considerations because what we found is that as programs start to try to adopt these practices, that quite often the staff get punished for doing the work. So they may be doing more outreach or more community ed or more coordination, and so their productivity rates go down and they get punished. So most programs have found that they have to adjust their productivity rates. Often they have to, they may have to meet with people outside of normal business hours. So there are a number of things around flexibility and being proactive that can be inconsistent with the system that is surrounding the person. And of course, there are also things that we have to work through related to, how do we finance this? How do we take what's working and apply it here? And where we can't apply something else, how do we work together to advocate for insurance parity and that sort of thing? So, just a couple of key points around the systemic considerations. Particularly in a rural community, the more you can look at your organization's mission, your organization's philosophy, and tie it to this work so that it's not a departure but an extension. And the more you can take the types of training that you're providing for the early psychosis folks and the types of processes and make those available, even if a person has been ill for 10 years, or even if a person has a different diagnosis, but it has that same kind of impact. Most of these practices are quite relevant. I think that we're going to turn it over to Ryan to walk through the next set of slides. Ryan, do you want to pick it up?
Yeah, I think today we're kind of going through the key goals of, or key goals / components of early psychosis programs, specifically now being called coordinated specialty care programs for early psychosis. the goal of this kind of coordinated response, this team-based response, is to make sure to provide people what they need when they need it, and obviously maintain continuity of care throughout the time that they are in the programs. So we want to make sure that these key coordinated specialty care concepts are in place. So that's that integrated team. In Oregon, we use the term transdisciplinary team, just to take it a step above multidisciplinary or interdisciplinary, meaning that we're all working together with a shared treatment plan, meeting frequently, very similar to the ACT standards, the sort of community treatment standards. So usually includes psychiatry or psychiatric prescriber, counseling and clinical case management, supported employment, supported education, if possible peer support, and occupational therapy are kind of the key components of the teams, at least in Oregon. We've had some good success with. You know, we like everybody to be trained in the same way, and even cross-trained to, you know, for example, having our case managers and our counselors go to peer support trainings and understand what the peer supports are doing. Consult with occupational therapists and know what their assessments are looking for and what cognitive things to pay attention to. You know, it's just basically understanding what each person does, so there's a mutual respect for that, and understand how each of the discipline's primary interventions are impactful with the clients that we are serving. One goal of the coordinated specialty care is having one treatment plan, which is a challenge that we found in Oregon to do. Some of our teams do it better than others, but where everybody has access to the plan, everybody can change the plan, and it's not just the social worker or the counselor that kind of maintains the plan, but the plan is actually a living, breathing document that changes frequently based on how treatment is changing or how the individual's goals are changing. And we know we're working with 15 to potentially 25, 30-year-olds, average age around early 20s, and this is a group that changes their mind a lot, which means goals are going to change a lot, and that's really consistent with identity development. So really like a setup where the plan can be easily modified by any member of the team based on what the client's current goals are. Do a lot of double teaming in our work. This might look like a counselor, case manager, OT, peer support attending a prescriber's appointment. This might mean 2 people going into the field for purposes of engagement. This might look at 2 people going in the field, 1 meeting with a family, 1 meeting with a client. This might mean 2 people leading specific types of groups. So a lot of double teaming. Yeah, again, I've already mentioned this, but rapid review of every person that's being served. So every week you cover every person on your team. You know, this is different than sometimes traditional treatment team meetings where we'll spend 45 minutes talking about 2 people that are really our high intensity clients. You know, really the research shows that you don't need that much time, and all that really happens is you forget about your other participants in your program who are doing better but are maybe not moving forward. So we don't want to spend too much time on very few people. We want to spend about an equal amount of time on every person, which is very focused on kind of what's happening next, not long psychodynamic assessments of their situations. Adequate intensity. So to do this, you actually have to have smaller caseloads. You know, basically we try to follow the ACT standards, which is 1 to 10 across the treatment team. And if we do have a lead clinician on a team, like a social worker or a counselor, we ask if they don't have caseloads over 20, or at least between 20 and 25. Obviously, this coordination doesn't just occur in the office, it occurs wherever. One of our big components of our teams is that when somebody is hospitalized, that somebody from the team is also at the hospital, meeting with the participant, or meeting with the client, and meeting with the treatment team. This can be when they're first being introduced to the program, or if they get hospitalized throughout the program, that somebody is there. We've found that particularly when somebody is there in the hospital for the first time, having a friendly face, that individual will attach to your team member, and you know, it's a great opportunity to build those relationships. They'll see you as the person that helps them get out. We've unfortunately lost a series of clients when we weren't in the hospital, when they were discharged, and then we weren't able to later engage them. So I think in short, coordinated team, very quick, intense, in the community, very similar to ACT. Oh, there it goes. Do you want to talk about community ed, Cameron?
Sure. Yeah. So, again, our goal is to teach people in the community what to watch for and to let them know that you're there and encourage them to call. So, a lot of people will call with folks who are not appropriate for an early psychosis program. And so we actually think about our programs as consultation services in addition to being a direct service team. So we'll get a lot of calls. In fact, probably 2/3 of the calls that we get are folks who either don't have any psychosis, that they've got some other kind of issue going on, or they've got a psychosis that's related to something other than schizophrenia or a bipolar spectrum condition, which is the eligibility that we have in Oregon. And so we're able to kind of walk through that differential diagnosis a little bit, help connect the person to resources. We actually put a fair amount of effort into that front end, and Ryan will talk a little bit more about that. But it's important as we do community ed to let people know that this is a very common condition. Psychosis is very common, that you're there to provide support, to talk it through with people, and that you're going to try to support them getting the help they need, even if the person's not appropriate. So you want to try to link it to other efforts. So suicide prevention, or whatever other kinds of campaigns might be going on. You're working with NAMI, having a really good brochure that you can use. We generally encourage states to have a common approach. So, common standards, one name, one logo, in order to facilitate being able to do statewide kinds of community education work. And again, the messages that you give are very, very important. That this is a normal condition, very common in adolescents, that it's very important to get help, but also that you can expect positive outcomes as a result of that. And of course, you want people to call. It's also very important, if you're going to do community education, that you have really thought through what you're going to do when they call, because we know that one of the causes of delays has been that people get bounced out of mental health services when they do call. So, really thinking about, not only how are we going to get the word out, but also how are we going to engage with people once they call us, right?
Yeah, so, and then once people do call and you actually have found them to be appropriate, then access is absolutely key. We have to, to the extent possible, remove every barrier we can to get people in as quickly as possible. We've spent tons of time in the last few webinars kind of talking about duration of untreated psychosis and the potentially terrible outcomes that can occur when people go for so long without being treated. So we've got to move very quickly. And one of those ways to assist people with access is to really focus on engagement. Tamara said earlier in this webinar that things like hope and relationship, aren't specifically listed as evidence-based practices. I might actually argue that I think they are evidence-based practices, and the best evidence-based practices is a choice because they tend to be in all evidence-based practices. So we do have to really spend some time on those key things that we know will support people in engaging in programs. So you have to spend the time engaging individuals. That might mean that you're working in the community, spending time just building a relationship. I mean, in Oregon, we don't require people to sign all the opening paperwork right away until we feel we have a relationship with them, or until the individual feels they're comfortable enough to work with us. We make sure that there's rapid access to medications when people are ready for that. All of our psychiatric prescribers hold time, or most of them hold time every week for new intakes or crisis situations. So people have rapid access to psychiatry, so usually we can get that in within a week. Rapid access to vocational supports. making sure that people have, when they want to move forward towards work or educational goals, they have access to those staff immediately. There's good research that suggests that if we wait too long on vocational educational supports, people's identity starts to shift towards that of a mental health patient, and we lose that opportunity to shift identity towards normal developmental practices. So really working hard to whatever the barrier is to service to kind of knock that out of the way. As you probably are all aware, sometimes with individuals with acute psychosis or conditions like schizophrenia, they may not be willing, able, or they lack insight into wanting to enter your program. So you're gonna spend a lot of time with families doing triage, problem solving, crisis planning, basically working to keep the person safe, as well as learning what strengths and interests the individual has that will allow you to engage in a conversation with them. So again, in short, being very flexible in our approaches, focusing again on outreach, being out in the community or wherever the person feels comfortable. Whether it be home, coffee shop, mall, park bench, basketball court. I've been at all of those places. And then, again, focusing heavier on those elements of evidence-based practices like choice, hope, relationship, that actually ultimately facilitate whether or not somebody's going to engage in treatment services. Engagement, yeah, we've talked a lot about that. I'm going to do a whole talk on just focusing on engagement and building trusting relationships, which basically means we have to let go of some of the rules that we're trained to do around making sure that people come in and take responsibility and take their medicines as prescribed. And we have to lose some of that clinical language. We are working with a key developmental area. And I have been doing this work for 15 plus years, and I have yet to have somebody with a true psychotic disorder come into my office and say, hey, you know what, I'm psychotic and I need your help. It doesn't work like that. So we have to really focus on engagement strategies which are just focused on building the relationship. There's techniques that I'll train on. One is a cognitive behavioral therapy technique called collaborative empiricism. Probably one of my favorite motivational interviewing techniques is LEAP, stands for listen, empathize, agree, partnership, and that is based out of the book I'm Not Sick and I Don't Need Help by Amador. Some trainers will charge up to $10,000 to $25,000 to train you in MI and various other types of treatment protocols. You can pick up I'm Not Sick and I Don't Need Help for $7.99 used on Amazon, which will give you, I think, some of the most valuable information in terms of engaging individuals and teaching. And also, there's also an element of teaching families on how to talk to individuals who don't believe that they have a condition. Yeah, I mean, you also have to train clinicians and all those very other unique issues related to early psychosis and ways to describe things that are much more empowering, kind of talking about more focused on symptoms and how symptoms are getting in the way versus syndromes. And even if you feel, or even if the individual is open to talking about a syndrome like schizophrenia, being clear that this diagnosis are not things that last forever. I mean, the authors of the DSM are very clear. The diagnosis is a snapshot, so things change, and not everybody fits nicely into those square boxes. And that sometimes the symptoms that they're experiencing, anybody potentially could experience, given given high levels of stress. Yeah, so making sure you're not using language like, oh, you have a lifelong illness, you're going to have to take medicines, you're going to have to go on disability. I mean, I've heard enough of those conversations and watched people just really go downhill based on those particular conversations. So again, I think Tamara mentioned another element of evidence-based practice is hope. So we have to have kind of hope for those individuals. Really focusing on the strengths and what an individual brings to the relationship from the very beginning. We're big fans of strengths assessments. We use the University of Kansas model and kind of doing full strengths of assessments. And then, yeah, and Obviously, sometimes if individuals are told that medicines are going to be all end all, we like to send a message that medicines are potentially one part, but they have kind of the most control on whether or not their symptoms are going to get better. That actually behaviors that they do or things that they engage in will actually help the medicines work better versus the medicines will help them to really kind of empower them in that way. I mean, I think the best evidence-based practice really is choice and empowerment. And then yeah, persistence. I mean, that's one thing with engagement. Sometimes it's try, and try again. I mean, we will go out to people's homes multiple times. We will take people to coffee multiple times. Whatever kind of is necessary to engage somebody. We have enough experience now that if we don't engage somebody in treatment, particularly someone that's developed the first episode of schizophrenia, that things usually, not always, but usually go downhill. So we're very persistent in trying to engage people in treatment. This is a core key component of our program. Obviously, this needs to be supported by clinical supervision because things that I've just described may not be billable if the person hasn't already signed all their opening paperwork. So again, that's where the set-asides and the extra funds can be helpful. As I mentioned, you also, as you know about these particular programs, that you'll be working with the families. Sometimes you'll be working with the families even when the individual's condition isn't at a place where they agree to treatment. So you'll be working with families all along, sometimes in crisis mode, all the way to transition from the program. Here are some areas that you'd want to pay attention to in working with families. Obviously providing education, that could be education about your program, education about the condition, and ongoing problem solving. One of our key models in ESA in Oregon is the use of Bill McFarland's multifamily psychoeducation groups, which again really is less focused on symptoms, more focused on week to week problem solving and reducing conflict and stress in the home. And not focused so much on what we do about schizophrenia, but more what do we do about setting good boundaries. Make sure you're talking when the individual isn't able to talk about their strengths, getting that information from the family and understanding what the family's strengths are. I've already mentioned, but you want to pay attention to safety and develop safety plans, and this could be done when the individual is at a point where they're not engaging in treatment. Like if you have an individual who's not engaging in good treatment, you're spending time with the family paying attention to warning signs, paying attention to symptoms, and where we might have to do something like take them to emergency room or call local law enforcement. One thing that our families have told us that have been extremely helpful is introducing them to other families with similar experience. Again, as part of the multifamily psychoeducation group model, about every quarter we do a psychoeducation workshop for families and individuals. And that's an opportunity for us as a team to provide education to the families, but it's probably more important that the families get to meet other families. So it's kind of a classroom setting. Everybody in our program comes together. It's like a workshop. And they get to meet each other and engage with each other. And of course, they get to do that in the ongoing groups. So we're not afraid to bring people together. In fact, we encourage it. Again, the goal of family education, whatever model you use, is to equip the family to respond as effectively and compassionately as possible. Some of the components of that, we have a set of ESA family guidelines that we give to every family as they come in. We have them all laminated that they can post on their refrigerator or wherever. I just heard yesterday that one of our families has now turned our ESA family guidelines into their screensaver, so they see it on their laptop every time they open their computer. So I think that was a nice use of the family guidelines. Certainly we could send those out. There are 20 guidelines of just things to pay attention to, when to give each other space, ignore what you can't change, carry on business as usual. Each of those guidelines sound quite simple, but there's really a psychobiological component behind each of them. I've already talked a lot about risk and crisis planning, making sure that you get education about the symptoms, what they mean. We'll talk a lot to families about why an individual might not understand why they have an illness and techniques to talk to people about that, what to pay attention to, what to ignore. Obviously allowing families to grieve, and in some cases providing grief counseling for the families, or at the very least referring them to another counselor outside of your program. Paying attention to kind of really we do a full family interview with almost all of our families to really try to understand what those early symptoms were, what did they see first, maybe even a year before they actually sought help, because that helps us predict the relapse signature. Early symptoms predict what later symptoms may look like. So if somebody was not sleeping for 4 days and the family noticed that, if we see a year into the practice that person is starting not to sleep again, that's a potential relapse warning sign. So we want to make sure that that stuff gets developed into a relapse prevention plan, which you can do with the family and with the individual. So again, we do a lot of teaching around communication, structured problem solving, really focusing on how to separate the condition from the individual so that unintentional blame isn't experienced by the individual. So even almost using more of a narrative approach, saying, instead of saying, this is what you do when Joey starts talking to himself, we might say, this is what you can do when Joey's condition starts to take over. You kind of can see the difference in how that's described. So we're not blaming Joey, we're blaming the condition. Obviously have an open process for feedback. We do a lot of focus groups. A lot of our programs engage in the feedback-informed treatment models, and that's for both the individuals and families. So they can give us feedback on what's working, what they need, what's not working. And of course, resources. We try to put as many resources as possible on our website, so at the very least our families can go there for resources. Another key intervention, maybe one of our more important interventions, is access to supported employment and education. We spend a lot of time talking about identity, and we want to shift the identity from being a mental health patient to kind of moving on in your normal developmental goals. For most young people, and I think our data suggests over 90% of individuals that enter our program have a vocational and/or educational goal. We want to make sure that we're having that intervention available so that that goal can ultimately be met. Again, we want to maintain their normal trajectory, or the trajectory that most young people want. So having, in some cases, a separate support employment education specialist as core members of the team. Our larger teams will have one person who's focused on support employment and another person who's support education. Our smaller teams will have one person that combines those elements. For supported employment specifically, we use the IPS, or the individual placement and support model, or at least principles of that model. Actually writing a paper right now that kind of talks about how to modify that model slightly, that fits more, that's a little more developmentally appropriate. There are some elements of the model that are more geared towards individuals with more severe and persistent mental illness. However, overall, the main principles of the model are very consistent with the work that we would do with young people, focusing on their goals, choices, rapid access to employment. Those principles are key. Obviously, we would be integrating strengths and career exploration. When I do supervision around this model, I really encourage the clinicians to work with the individual to try to understand what the barrier is around careers. Sometimes we throw out terms like lack of motivation, probably too much. Sometimes it's a lack of knowledge. Sometimes it's a lack of understanding. So we will focus a little bit more on career interest inventories, understanding the world of work, understanding the resources necessary to get a specific job, and then moving in a step-by-step process. Often it's not unusual for us to work with our occupational therapists to kind of understand what some of these other barriers might be to employment. They might need accommodations for cognitive or sensory symptoms. And then certainly we want to pay attention to side effects of medications or side effects of other forms of treatment that might be getting in the way of employment. It might be hard to start a job at 6 in the morning if you're on a high dose of Zyprexa or something. It might be more challenging to get up. So working with the physicians and trying to find the right balance of medication that allows people to continue with their employment or educational goals. Obviously, we talked a lot about the use of psychiatric prescribers. That should be no surprise that we certainly have psychopharmacology prescribing as part of our programs. So the goal of that is to reduce the impact of targeted symptoms and to optimize health. Obviously, our medical guidelines really focusing on minimizing side effects. We generally know that individuals will experience the bad parts of medicines before they experience the good part of medicines. And for some individuals, even though they're having positive effects of the medicines, they may not recognize those positive effects. So really focusing on minimizing side effects. We also know that because of these side effects, one of the more common side effects with at least the newer medications is metabolic syndrome or symptoms of that. So ongoing health assessments and ongoing education about what individuals can do about that. Obviously having routine lab work, focusing on exercise, nutrition, good sexual health, and obviously reducing substance use, things that can get in the way of effective medication. Going back to my original message that what you do can make the medicines work better, not the medicines work on you. Obviously, we use counselors and social workers to do a wide range of interventions. We're not a program that really focuses on one overall psychosocial model. We use a variety of interventions and train our clinicians on a variety of interventions because, as Tamara said, what we know really works is the building of alliance. An alliance is made up of hope, alliance is made up of relationships, alliance is made up of what the strengths of the individual that the person already brings in, and sometimes alliance is made up of the specific intervention, but that is a tiny percentage of what facilitates change in the therapeutic alliance. So we use a wide range of strategies with some overarching principles, some of those principles being very person-centered, very focused on hope, focused on building relationship, very kind of practical supports for school and work, being very goal-orientated, not necessarily process-orientated. Obviously, what intervention we used is guided by the person and what they're very much interested in and where they are in their stage of change. So kind of in ways implementing the old trans-theoretical model. You know, if somebody is pre-contemplative, then we'll use motivational interviewing. If they're contemplating, you know, that's when shared decision making can come in. You know, really just doing some good solid treatment matching. If there are things that we do maybe stress a little more than others, development of relapse prevention plans. That's a big one in our program. When the individual does have substance use, we're definitely not following an abstinence-based model, focused more on harm reduction, recognizing, given the individual's developmental stage, that drinking, use of other drugs may be, in some cases, developmentally normal. Marijuana is legal in our state, so we have to kind of work around that. And then really kind of testing out these strategies which are recommended in early psychosis programs. Obviously, cognitive behavioral therapy gets a lot of attention. It can be a very effective model if the person finds it effective. So really kind of throughout the process, whatever we're doing, we're going back and asking them, is this working for you? Is this helpful? Or is the intervention that I'm using targeting your specific goals? So kind of that overarching role of kind of feedback, regardless of what intervention that we're using. Obviously, motivational interviewing is big. Use of mindfulness is getting a lot of attention. A lot of our clients are finding that very helpful. Tamara mentioned this earlier, but social interactions. A recent published study was suggesting friendship may have a huge impact on individuals' long-term recovery that may be greater than that of medications. And this study wasn't even necessarily referring to peer support. It was referring to just helping individuals build natural supports like friendships in their communities. I mentioned shared decision making. Shared decision making again is an intervention that's getting a lot of attention in the early psychosis world for good reason, kind of given that it's a very kind of empowering technique that forces us as clinicians to kind of explore options with individual and come up with a decision together. You know, it's kind of it works. I actually find that it works really well with motivational interviewing. Again, motivational interviewing can be used when the person is really ambivalent about change, where shared decision making gets used when there is a decision to make, and when the person's ready to make some type of decision, and this decision could be anything across the board. It involves like a three-step process. In short, obviously it's much more detailed than I'm going to describe it, but just to give you an idea, it involves 3 steps. First step being team talk, and that's when you explain all the alternatives to the individual in a way that you're not telling them what to do. You're just describing alternatives. Then the next stage is option talk, where you describe the alternatives in more detail. And then there's a wide range of decision support tools that can be used to help the individual make a decision. And the final step is decision talk, where the individual will make a decision based on their personal preferences and those decision support tools. Most of the early psychosis programs around the country and around the world are transitional in nature, meaning that they're short-term being anywhere between 2 to 5 years. I really feel the success of an early psychosis program is not the success that the individual makes during their time in the program, but what happens after they leave the program. And in order to kind of have that long-term success, we as programs need to be really focused on transition, and we probably need to be focused on transition the moment they enroll in the program. So again, strategies around that are encouraging long-term hope, recognizing, however, that recovery can take an extended period, that as someone completes your program, that may not be it, that recovery is ongoing, and the transition from one thing to another actually is a normal process. Obviously, throughout the process, continuing to ask whether what you're doing is working, and if not, you're going to be trying a different strategy, and that's, of course, informed by the individual. By doing that throughout the course of your treatment, you're actually training, or at least modeling for the individual to do that once they leave your program. So they're talking to other providers about choice and giving them feedback so they get the best treatment or the treatment that works for them. And really evaluate your long-term needs. You know, what happens when somebody leaves and they have a relapse? Is there a safety net that your program can offer? You know, for example, some of our programs allow individuals to stay in our multifamily groups even after they graduate, just to allow them a safety net. I, in particular, am paying attention to those long-term outcomes, because unfortunately, some of our long-term outcomes are not looking as good as we would like, at least at an international level. We don't have our long-term outcomes in Oregon, but internationally there are some bumps, and we need to pay attention to that and to pay attention to what we're doing kind of throughout that process and how we can give long-term supports.
Okay, so I guess I'm going to pick it up from here. And I think, Ryan, in talking about the transition, that's a very, very important topic, because it relates to outcomes. And one thing he didn't mention was that we do, at the point when someone transitions out of our program, we have a process that requires about 6 months where the person is actually connected to the long-term care that they're going to be receiving, and there's a gradual handoff, as well as kind of checking back in over time and giving people the message that they can call if they're having a problem. So I still get calls from families that were in the program 10 years ago or longer, when something's come up and they're not sure what to do, and so we really see it as a long-term investment. And the things that we've walked through, we've just kind of introduced, and each one of them is a significant body of knowledge. So it takes some time to really incorporate all of these elements, but they're all really critically important. And I think also, as we look at what we do, the bottom line is, are we having the impact? So, I learned a long time ago that having a really great plan without the commitment doesn't work as well as having a really terrible plan with the commitment. And so, you know, some of the folks who I've seen be the most effective, you wouldn't think would necessarily be considered the most effective clinicians based on their training, but they really were able to connect with the person and help them make progress. And so in the end, you know, a lot of it is about attitude. So as we think about evaluating, you know, it's important to look at whether what we're doing is actually working. Are we engaging with people over time, you know, or are they going to the hospital without us ever having met them? And then if they do go to the hospital, are we engaging with them then, you know, before they come back out? You know, are they continuing to work towards vocational outcomes? Or are they just going straight onto the disability system and giving up on work? And then, you know, at a systemic level, you know, how are we doing in terms of our ability to pay for the services? You know, do people have insurance? You know, are we able to actually access the revenue that we need? You know, even though that's not an individual outcome, it's certainly an important one for, you know, thinking about the long-term process. And then incorporating ongoing feedback. So, you know, one of the things that we've done in Oregon is we have our own practice guidelines, and then we have a fidelity tool associated with those guidelines where our programs will do self-assessments, and then we'll also every couple of years go directly to the program and walk through that assessment process and make recommendations, and then we'll work on additional training or support to improve. So we always think about the work that we do as moving towards an ultimate goal, and that goal keeps kind of shifting as we have success, and you're never quite there. So it's an ongoing process of trying to learn from the data and from the direct experience. So, you know, we were going to talk a little bit about resources that are available to support programs like yours that are just getting started. And this slide shows a checklist from the implementation manual from the Raise Connection study. We have a manual as well that kind of dovetails with that one. That's basically a checklist of here's what you do first and second. Here's some decisions that you have to make. So, you know, you really have to think about, okay, how are we going to create this program? Where is it going to fit? Who does it fit with best? Where do we have the best clinical supervision? Where are we best able to do outreach? You know, which program or which place is best for our community? And every community makes that decision differently. So these programs can be housed with ACT teams. Sometimes they're in children's programs. Sometimes they're in adult programs. Sometimes they're combined with crisis programs. And then also thinking about what geographic area is this program serving. So again, you have to do a lot of outreach. And you also want to have kind of a critical mass of people that the team is working with. So that's a really important decision about, you know, how are we going to set those geographic boundaries. And then if you have a really small population, which you guys pretty much all do, then how do you think about that on a regional basis so that you can share resources? If you don't have quite enough capacity, you know, how do you pool resources across your programs? Who are you actually going to serve? So a lot of programs just kind of pick up the research criteria from one of the RAISE studies or something, and they say, this is who we're serving, without really thinking through the public policy implications. A lot of research studies have very narrow criteria based on the controlling different factors and the kinds of requirements that they have from their institutional review boards. So you really have to think about how broadly are we going to define psychosis? How early are we going to try to identify people? Are we going to think about doing psychosis risk syndrome, or are we just going to do first episode? If you know, and there are different considerations that go into that. Who else is working on this that we can partner with and look for synergy with? How are we going to pay for it? You know, and that's based on how many people we think we're going to have and how many staff people we think we need. And then you start getting into the community education. You know, trying to make sure that everyone's educated about who you're serving, what you do, how to get to you. And this particular checklist talks about establishing a referral network, but we also really emphasize that community education starts with your front desk. It starts with your crisis team. You know, it starts with anybody in your own agency that's going to likely be interacting with folks, and then you want to get to your hospitals and, you know, people in the crisis system, and then kind of keep building out to the schools and the church congregations and that sort of thing. You know, so looking at your procedures, your oversight, staffing, et cetera. So, and then, you know, how are you going to do your long-term planning or your long-term training? So these are all, you know, things that people have to work through. It often takes a while to figure it all out. You know, it's not uncommon for the planning process to take 6 months. I think before we started our program back in 2001, they had spent an entire year. They spent 1999 researching. They spent the year 2000 planning, and in 2001 we actually started the program. And we still didn't have a very good plan, but we figured it out with time. The good news is that there is almost more resource out there than people can handle. And so, you know, it's just a question of how do you target that so that it's most helpful for you. So I started with the National Association of State Mental Health Program Directors. I think they're very helpful for communities that don't have a lot of resources, where your federal block grant dollars are not, you know, in the millions of dollars like, you know, the state of New York. NASHBID, as they're fondly referred to, actually has helped to fund. They get consultation money that is available to programs that don't have a lot of resources. And so we've actually worked with several different states through them, where they're able to fund 10 days of training and consultation. And so they, you know, I'm not sure where they're at with that this fiscal year, but it's definitely worth checking out if you're interested. And then also their website has a technical assistance section with an early psychosis intervention tab. And if you go to that, you'll find that they have they've tried to compile all of the different resources that have been developed. So they have psychoed materials for families and young adults. They have program guidelines. They have webinars. They have links to videos. So they've tried to put together kind of a comprehensive kind of summary of all the things that are available. And also on that site is a document that we actually helped to create called Key Decision Points, Steps and Key Decision Points in Starting a Program. And we use that to kind of help people walk through the process. You know, we mentioned RAISE a while ago. You know, these are a couple of research studies that were funded through the federal government, and they have created a number of really useful materials, including outreach materials, training, videos, manuals, psychoeducation handouts, and they're all online, easy to access. We also have our own toolkit of materials on our website. We've tried to design our website so that families and young adults can actually go there and find things that are directly useful for them. And then there are things being created as we speak. So to the degree that you don't find something that's targeted to your needs, there's probably somebody in the country right now who's working on it. And that relates back to PEPNET. And actually, I think I left out a word here. It's the Prodrome and Early Psychosis Prevention Network, so there are 2 Ps. But anyone can join. It's free. And it's a place where people from around the country are combining efforts to address common issues, including what do you do in rural communities, and then to share information about what's available. The International Early Psychosis Association also has a free membership, and you can get a really nice journal that they do that's free. And they do conferences every couple of years. The next one is in October in Milan, Italy. So there are some people from the United States going to that. NAMI Minnesota put together a booklet specifically for families dealing with early psychosis. NAMI National has been compiling resources and also has a whole network of folks supporting local people who want to help with these programs. The National Council on Behavioral Health has material up there. And then the Partners for Strong Minds is another new organization that's focused entirely on trying to get the word out about the importance of early intervention and the availability of programs. Ryan and I are co-facilitating a learning community that's being funded by the National Training and Technical Assistance Center for Children's Mental Health. And we are going to be working with a small group of sites to walk through a self-assessment process and to kind of help get things started. That's going to be April through December of 2016, and we've already had a number of folks who have responded. Looks like that group is going to include some very, very experienced sites, as well as some sites that are just in pre-contemplation, just trying to kind of think about it for the first time. And what we're doing is we're opening it up to anyone who's interested. We have an application form that we can send everybody, and there are different ways that you can get involved, including just receiving information and being invited to things, or doing more of an intensive process. So it's really, it's going to be very tailored to the folks who respond. And we'll be actually developing materials specifically based on what's requested. So let's open it up for discussion. We've just thrown a whole lot of information at you, and I have no doubt that it's overwhelming. We've tried to summarize it in a way that's digestible. Again, I keep coming back to the importance of just really being clear about why you're doing what you're doing, because that makes all of the components much more coherent. So, any questions or comments, thoughts about how this might apply in your community? And Jenny, if you could open it up to unmute everybody, that would be great. Or you can write in the chat box as well. Any last words, Ryan or Ari?
No, just appreciate the time and happy to follow up with any questions you have. It was a lot of information and it was broad, so happy to get more specific if that's necessary.
This is Ari. I don't have any final comments, but thank you.
I know it takes a while to process the amount of information that we've covered, and we did receive some feedback before from folks that it's that people are digesting. So I'm curious for the folks who are on the call, is there anything about what we've said that raises questions or concerns, things that you're kind of puzzling about?
This is Patty and Douglas. I just have a comment. I don't really have any questions. It was a lot of good information, and just keeping the clients engaged, I think, is so important, because once they get that comfort level with the group they're working with, I think that really can help. And I really like the part about having a relapse plan. to prepare for, what's coming up and be with that family so that when it happens, they have a plan to kind of surround that person and get them the help.
Yeah, I think those are definitely two of the absolutely essential elements. And we end up doing a lot of problem solving with folks around that engagement, because it is challenging sometimes. And the young adults tell us about how often it takes them a while to really trust. That it can take 6 months, and sometimes it's even taken as long as a year. And so just really trying to come up with different strategies. Peer support can be really helpful there. We had one young woman who's on our leadership council talks about how she went for an entire year not talking to her clinician until she met the folks from the leadership council and really was inspired by them and went back and started talking. That persistence is really important, and often it's the families who are the most engaged for the first 6 months or so. Sometimes only the family will talk to you. And you can go through the relapse plan with the family. You can do a lot with the family.
Absolutely, and I think, this program is so helpful to the families, too, because, when you live with somebody that has a mental health diagnosis and they're severe, it can be overwhelming and very tiring, and so to have that extra support of just, having that assistance there, I think is great.
Yeah. I mean, the one thing that, I know for sure is that you just can't do this alone as a family. It's really not possible. I mean, you really need partners, and so families are so deeply appreciative towards the service providers because they have such a great need, and it's really wonderful work to get involved with because it's so gratifying because you see the impact of it. Just by providing some education, it changes the way families approach it and the way they think about it. And you can really see the impact of the work that you're doing, which it's really great because when I first started in the field, my first job as a case manager was back in the early 80s, and there was this kind of pervasive hopelessness in the field at that point. That was really demoralizing for the clinicians as well as for the family members and the young adults. And now, it's so profoundly different than it was then. Now it really is hopeful at a very, very different level. So I think that also makes it a lot easier to engage people when you actually believe in them.
Absolutely. We have a 6-person adult group home here, and so it's a transition home. We get them from a more intense place, and then we transition them back out into the community. And when we first opened that, just the response we got from our community was kind of, scary. They thought that we were going to have people that were out of control, and, it's taken a lot of time to kind of educate people that these are people that, could be your family member, that just struggled at some point, and we surround them with care, and, they have supervision 24 hours a day. And, some people I've talked to, I've told them we've had artists, we've had chefs, we've had, most of them are very high-functioning people, and so I just think it takes that education to really let people understand.
Yeah. I think what you're describing is a really great way of framing it. That you have people who bring these really remarkable talents. That basically what you're trying to do is to help them contribute those back to society. And I think when people talk about mental illness, often they're thinking about some abstract thing or some homeless guy on the street corner who hasn't been able to shower for a while or something, and they're not necessarily thinking about, the kinds of talents that these folks bring. They're not really seeing them as people. And so I think the more that we can really appreciate and bring out those talents, and the more people start to feel safe to talk about their experience, and actually, talk to their neighbors and their church, and be more visible. The face of what mental illness looks like, it changes.
Absolutely.
Yeah.
I'll quit talking. I could talk all day. So.
That's great. That's great. And I think one of our goals with these webinars was to try to connect with folks who are kind of natural champions for this kind of work. Who are going to be kind of the emerging leaders. And so it's really great to see that happening, and to get to know you a little bit.
Thank you. Yes, I do have a passion for people with mental illness. I have it in my family, and I just feel like so many times people are misunderstood. And, they see the illness, they don't see the person. And so I try to be a spokesperson as much as I can for them.
Yeah, that's great. That's great. Are there other questions or comments, requests, observations? One of the things that we teach people as they're interacting with folks with psychosis is that it's really important to become comfortable with silence. Recognizing that it takes people time to process information. So, we know that one of the impacts of psychosis often is that people have a reduced information processing speed. And so it takes a while both to digest the information that they receive and also to express their own feelings. And so as much as sitting in silence feels uncomfortable for people, it's actually a practice that we encourage.
Hey, Tamara, could you please go back to the slide before the national resources slide? And just to let everybody know, this presentation will be available to you, and a follow-up email will be sent to all of you who have visited us today with a link to be able to download or watch the presentation again.
Was there a question about this slide?
Joanna just wanted to see it.
Okay. All right. Yeah, and we'll spend a little bit more time talking about that process of getting started on the next webinar. So I just wanted to kind of introduce you to the fact that there are people who have thought this through in terms of what the steps are. The tricky thing, as you start looking at some of the resources that are out there, is that you find that there are some assumptions attached to them. So, for example, this particular checklist came from the Raise Connections program, which is a pretty, the way they developed the model is fairly specific in terms of, that you have one of these clinicians and one of these clinicians, one of these clinicians, and they do exactly these things, and, there's a caseload of 30, and, that isn't going to work in a small community where you're never going to have more than 10 people in the program. So that was why we developed the additional resource around steps and decision points, because there were things that were not being addressed in some of the research-based literature that's been created. So you have to, just like Ryan was saying with the evidence-based practices, you have to adapt them to the population that you're working with, the culture, the geographic considerations, the staffing patterns. The same thing is true in terms of how you go about implementing the program. I think we could probably call it. We'll be back online next Thursday and have plenty of time for questions and answers. And in the meantime, if you want to send us any or include comments in your evaluation, we'll be sure to pick back up on those next week, if not beforehand. All right, well, thanks, everybody. and have a great weekend.
Thank you very much for joining us today, and we look forward to meeting again this time next week.
Thank you.
Thank you.
Bye.
Take care.
Bye-bye.
Bye.